For this session, I would invite Dr. Ansisha, Dr. Lal Daga, and Dr. Pinkesh Parmar as moderator, Dr. Manik Chopra, Dr. Ramesh Patel, and Dr. Jayesh Mania as chairpersons. Chairpersons, moderators, please introduce the speakers.
Hi, good afternoon. Hi, this is Manik.
Hi, Dr. Manik. Dr. Manik is one of the leading interventionists who does a lot of tower, and he's the right chairperson for the session. Over to you, Dr. Manik.
Thank you. So today we are here to discuss a case of a 68-year-old male with exertional angina with mild COPD, control on oral medication, occasional inhalers, normal coronaries, low coronary uptake for LMCA, and suitable anatomy, STS score intermediate, severe aortic stenosis. So it's to be discussed against TAVR versus minimally invasive surgery. I welcome all co-chairpersons and moderators. It's over to Dr. Abhishek Rajpopat to speak on behalf of transcatheter aortic valve replacement as a better strategy. I think we finished their presentations first, and then probably at the end we can take questions for discussion.
Okay, now I can share the screen. So first of all, I would like to thank you, Kamal sir, for giving an opportunity to be the presenter in this panel. And thank you for giving a very specific case scenario so that the discussion can remain very well into the streamline. So as Dr. Chopra has already discussed about the case history, so 68 years old male. So we have a couple of hitches when we are discussing SAVR versus TAVR as far as our published guidelines are concerned. So it's a 68 years old male, COPD, low takeoff of left main, and STS risk score intermediate. And we are discussing the best strategy out of this. So I think we have 3 points to debate, or other 4. One is the modality, another one is the mode of what are the controversies. So first of all, let's go to the what guidelines says. We have 3 major trials for intermediate risk patients: Certavi, Partner 2A, and Sapien 3 intermediate risk. What ESC 21 guidelines says, in a patient with increased surgical risk, there is more than anything which intermediate and above, we have to have a hard team discussion, and it should be decided as a patient, but we have to take care of other things like frailty, porcelain aorta, history of chest radiation before we take a call on that. But it's clearly mentioned that TAVI is preferred modality for the patient who are elderly. So now, again, the debate will start. What is 68 elderly? These are lines from Partner 3 trial, where it says clearly that interplay age is just a surrogate for life expectancy. The interplay between the expected life expectancy and prosthetic heart valve durability is the key consideration we are discussing, because you take a young patient, redo, repeat procedure. So merely because if you see the Western countries, developed countries, the life expectancy is in the range of 84, 83, 82. But if you come back to India, our life expectancy is 69.27, that too before COVID. So our Indian patient lives more than a decade lesser as compared to the Western counterpart. So if they are saying 75 is the age for TAVR, I would like to correct that statement and bring it back to the lower one as per our country's life expectancy status. Second thing, what our surgical colleague debates is the durability of a TAVR valve. They debate that you are crimping the valve, you are crushing the leaflet. This is the 6 years data from the Notion 1 trial, where at the end of 6 years, the prosthetic valve deterioration at the end of 6 years is 4.8% with a TAVR and 24% with a surgical aortic valve. So putting the surgical aortic valve is always a second choice as far as you are using the bioprosthetic valve. What we are missing, basically, the small annulus is the problem. These are information from Notion 1 data surgical arm. In a Danish population where the males are 6 feet or 6.5 feet and females are 5 feet 6 inches to around 6 feet, 40% of the surgical valves were 19 and 21. What is happening in India? 80% or more than that of a number surgical heart valves used are below 21. So what happens if you just roughly calculate the body surface area of a male who is 5 feet 9 inches and 70 kg, that is 1.8, and if you take a body surface area of a 60 kg female and 5 feet 3 inch height, that is 1.6. So this is the expected orifice area of a Medtronic freestyle valve. Even if you put a 21 millimeter valve in a 1.6 body surface area, you are having this effective orifice area per centimeter square per meter square is hardly 0.84. And for a male, it is 0.75. So what is happening, if you see the definitions of the outcome, index orifice area, even for a female, 21 valve is putting this patient with a moderate prosthetic valve mismatch. And for a male, it is a severe PPM you are giving upfront. This is from the Danish population. We are having Indians are making it. For us, the life is more worse. So putting a surgical valve is always a second choice because you don't have orifice area to fight with. Why surgeons are saying that our valves are much better? Because their studies said the freedom from the surgery and death. They were if you need a resurgery, then there is a valve has failed. But now the task force guideline says what is the structural valve duration. If your gradient, peak gradient increases by 40 or mean increases by 20 from the baseline, or velocity increase by peak of 4 or mean of 2 from the baseline, or severe valvular regurgitation, that's a severe structural valve degeneration. So the definitions were not appropriate at that time to analyze the results of those particular modalities. So now the third point of debate comes the low coronary. I would say, just having a one number, we have to understand low coronary from the annulus, that's the one information. It is nothing to do with simply the coronary. We have to look at the aortic root complex as such. Next in the line is here, the IFU manual of Medtronic core valve does not mention anything about coronary height. What they demand is the size of sinus of valve size. This is very important question. Somebody can criticize your CT report just by saying that, your coronaries are very low, you are not fit for TAVR. That's not the situation. We are going to the next stage of analysis. That's the expected leaflet to ostium distance, which obviously takes consideration of the sinuses. If your ELOD is more than 2, the chances of coronary occlusion is very, very rare. Here you take a distance from center to annulus, which is indirectly the leaflet length matching thing. And then you take from the origin of the coronary midpoint to the center line. That is where the coronary obstructions are defined. On top, we have novel valves, where the valves are taking support on the top of the leaflet and keep the coronaries clean. We are lucky to have this upcoming Boston accurate neo valve, where the upper crown sits on the top of the coronary, keeps the leaflet inside the sinuses, and in their IFU, the coronary height has been brought down by 33% from the other valve which are recommended. So just having one reason, you have one coronary lower, that person should not exclude the TAVR. Our index patient is an intermediate risk patient, but yes, in a desperate situation, we can use a coronary protection just to ensure the coronary does not close, which can be used for both balloon expandable valve and self-expanding valve. In balloon expandable valve, you bring the stent above the crown level, and in self-expanding, you bring it above the STJ. And we can certainly keep the coronary patent during the procedure. I would not recommend for intermediate risk patient, but yes, if the patient is at extreme risk, we have our weaponaries to ensure that patient goes out of the cath lab safely and lives the normal life. Our surgeon has to understand that the surgical valve does not have much variety, but our transcatheter heart valves are evolving rapidly, and they are having multiple options to ensure that a given patient from the differences or many variety of the coronary aortic root complex, we are able to tackle them. Now, if we just think from the data, where the MICS versus TAVR data, we don't have actually any head-to-head trial. Whatever information we have, it is from the propensity match data. No patient in this data was operated after 24 from where the second and third generation valves were introduced. So if you say any data propensity match, and those are from the single center, big centers. India doesn't have those kind of centers like Stanford. We have to see what is happening in the hands of average or regular cardiac surgeon in India. Not everybody in India is an expert of minimal invasive. If my surgical colleague thinks that minimal invasive AVR can replace the TAVR, then I would say only one thing: जिस अफसाने को अंजाम तक लाना न हो मुमकिन, उसे किसी खूबसूरत मोड़ देकर छोड़ना ही अच्छा. Thank you very much.
Thanks a lot, Abhishek. It was really very well summarized, and I would ask Dr. Jaideep Ramani to probably present his thoughts.
Okay. And right now the operation theaters will look like this. So it has completely replaced with total videoscopic, total endoscopic, or even total robotic works. So basically, if you look at the evolution of minimal invasive any case, it has been evaluated over these 5 stages. First is the direct vision mini thoracotomy or mini incision around 10 to 12
Jaideep,
centimeters.
can you make it full screen?
Yeah, it is already full screen. It is already a full screen.
No problem. Go ahead.
Okay. Then third one is video directed or robotic assisted surgery. Fourth one is the robotic telemanipulation, and last one is percutaneous, what Dr. Abhishek Rajput.
Your slides are not moving. We are stuck with the hybrid lab photograph only. So,
okay. Now is it visible?
yes, go.
Okay.
Yeah.
So this was what it right now looks like. There is always a debate between cardiologists and cardiac surgeon for TAVR as well as TAVR or TAVI on minimal invasive versus open heart surgery. So basically goal is STS database. What is minimal invasive cardiac surgery? Is any form of procedure which is not performed with full sternotomy with or without CPB support. So basically we have to look for only two things. First one is invasiveness and second one is requirement of CPB, that is cardiopulmonary bypass. So there is always a question, can we get rid of open in case of open heart surgery? Yes, right now it is absolutely possible in each and every case, whether it is coronary, valve, congenital, whatever the thing, it can be done through the minimal invasive route. So if we talk about the minimal invasive aortic valve replacement, we have got two different options, two different approaches. One is mini thoracotomy versus mini sternotomy. So according to STS database, minimal invasive cardiac surgery, what does it define? It is the procedure which is not performed with full sternotomy, maybe with or without CPB. Then we have to discuss basically two things while considering any case for minimal invasive cardiac surgery, that is invasiveness and CPB, use of cardiopulmonary bypass machine. So in every question is that can we get rid of open in case of open heart surgery? Yes, it is 100% possible right now with coronary, lima, radial, in any form of valve like aortic valve or mitral valve, it is absolutely possible. So minimal invasive aortic valve replacement can be performed by two different approaches. One is mini thoracotomy, second is mini sternotomy. So if you look at the journey of minimal invasive aortic valve, that starts from conventional, means that is a full chest or full sternotomy, to half or J sternotomy, and right up to the right anterior thoracotomy. So before deciding for any case for posting for minimal invasive aortic valve replacement, you have to basically consider few of criteria. First, adequate size annulus. Adequate size annulus means annulus, it will decide whether you can go for the thoracotomy or mini sternotomy. Our criteria is that if annulus size is less than 20, then preferably we go for mini sternotomy or J sternotomy. And if annulus size is above 20, then any of case it can be done through right thoracotomy. Second important thing, it should be free from extensive calcification. Though extensive calcified cases can be also done very easily, but there is some difficulty in doing such kind of cases through thoracotomy. But with small sternotomy, it can be done very easily. Third important thing, there should not be any intervention of aortic valve. But still, personally, I have done few Bentals with minimal sternotomy routes also. So if aortic root or ascending aorta replacement, it can be, if it is required like a Bental procedure, it can be also done. So pre-operatively, you may require, first one is TT, that will exclusion criteria means required, that is small aortic root and extensive calcification of annulus. Even in case of small aortic root, the root enlargement by Nix or Manugian, it can be also done very easily through either it may be half sternotomy or through thoracotomy route. CT evolution is always required. In CT evolution, we basically look for two things. First one is the angle from angle of aorta. If aorta is rightward, means more than 50% of aorta from right sternal margin. And second one is distance from ascending aorta to sternum, it should be less than 10 centimeter. If these two criteria fits, then mini stern thoracotomy, minimal invasive aortic wall replacement can be done very easily. And third important being that is angle. Angle means that is the vertical line which is drawn up to middle of annulus and transverse line through the middle of annulus. So if this angle is more than 45 degree, then you can directly approach the aortic wall through the mini thoracotomy route. But routinely we don't do this such kind of investigation. Then important being you have to evaluate the aorta as well as the bilateral femoral arteries. If it is totally occluded, then mini thoracotomy aortic wall replacement is practically contraindicated. But yes, mini sternotomy aortic wall replacement still it can be done because you can directly cannulate the ascending aorta. Sometimes the pleural adhesions may also create a problem while doing a mini thoracotomy route, but still through mini sternotomy it can be done very easily. So these are the few data which shows the minimal invasive aortic wall replacement which requires reduced ventilation time. It has the lower incidence of new onset of post-operative atrial fibrillation because there is less heart manipulation is done. It is shorter ICU stay. Most of our patients are out of ICU within 24 hours. And all our hospital stay is significantly reduced because most of the patients are discharged on third day evening. So these are the few photos I am showing you which when minimal invasive aortic wall replacement has been done. This is 12-year-old boy with Down syndrome with congenital aortic wall replacement is done. This is degenerative aortic stenosis elderly patient of 80 years. So bioprosthetic valve has been implanted. These are the few young patients where minimal invasive aortic wall replacement with mechanical valve is done. And this one is photo of through upper half sternotomy where mechanical valve has been implanted. So minimal invasive aortic wall replacement right now, I can say it is 100 out of 100 patients. It can be easily possible, but there are the few exclusion criteria or few things you may require like patient's renal function, patient's liver function. They should be also considered because these all procedures to be done on pump, and on pump the pressure fluctuation is also very commonly seen. Otherwise, whatever the profile of the patient, whatever the bad wall condition, whatever the small aortic root, 100 out of 100 patient, minimal invasive aortic wall replacement can be done very easily. Thank you very much.
Well, thanks, Dr. Jaideep, for this presentation. Now, I would invite questions from other co-chairpersons and moderators and other attendees.
Thanks, Dr. Jaideep Ramani sir and Dr. Abhishek sir for nice presentation. I'm Dr. Jayesh Penya. There is a significant or non-significant increase of, my question is to Dr. Jaideep Ramani sir. There is a non-significant increase of stroke, that is for the surgical patient, and also there is a higher incidence of AF in particular surgical patient. So what are the percentage of that AF and disabling stroke in case of mini surgical patient, minimal invasive?
See, in case of minimal invasive surgery, the incidence of stroke is same as open heart surgery. But we usually, during the surgery, we usually take care that small debris or small particles, they should not embolize to the heart. So we, after cutting the valve, we give repeated wash. That is same as given in case of open heart surgery or minimal invasive surgery. So practically incidence of stroke in minimal invasive aortic valve surgery is still less. See, we have done almost, I can say more than 100 minimal invasive aortic valve replacement in last 3 years. But till in not even a single case we ever mentioned, we ever noticed any incidence of stroke. Yes, there may be the chances of retrograde embolization in few of the patients, like through the femoral artery cannulation, but still we are lucky. We never experienced such kind of things in ICU. So minimal invasive aortic valve replacement, still incidence of stroke is absolutely less if you take care intraoperatively, if you take care of the small articles while cutting the valve. If you give a proper wash, then chances of embolization is still very less.
All right. Any other questions by moderators and other chairpersons?
I am Dr. Ramesh. My question to Dr. Jaideep is that in minimal invasive aortic valve replacement surgery, perfusinists is always saying that, sir, drainage is very, very less. We are having in, they are always having less reservoir, less volume in reservoir. So what is your experience?
See, generally we have a fixed strategy of using the fixed cannula. Whatever the weight of the patient, aortic cannulation, we use 17 FR aortic cannula, and for peripheral venous cannulation, we use almost 20, 24, 29 or 30 by 33 venous cannula. Your perfusionist should be smart. If even in cases if you have some problem with return or this thing, you can always cool down the patient to 30 or 28 degrees, so it will basically reduce your flow, and surgery can be done very easily. So I think your perfusionist should be well trained in doing the various cases of minimal invasive cardiac surgery. We are very lucky to have good perfusinists. So return problem, yes, it happens, but over the period of time, these problems are usually, they can be very easily overcome. So we never found such a problem while doing any cases. This month also we operated almost 8 cases of minimal invasive aortic valve replacement through sternotomy and thoracotomy, but everything goes well. There is not an issue. So always cooling down the patient, that solves almost 90% of a problem related with the small cannula or venous return.
All right. So I think most of the questions are being answered, and we are also running short of time. It was a very good discussion. Only few things, probably if time permits, I could add. One is, as correctly pointed by Dr. Abhishek, that most of the Indians would be having a small annulus, and typically we find that surgical valves are undersized most of the times. So in general, now there is a trend that before you take, even, I'm not criticizing, but I would say that surgeons should start assessing the annulus by doing a CT scan so that they know the exact number before upfront. So what is the actual annulus of the patient? It would be better assessed by CT scan rather than assessing on echo, and probably your intraoperative assessment, of course, would be there, but this would be an additive tool, I would say. And second thing is that regarding the clinical scenario which was given to us, of course, the coronary height was very low, of around 5. But it's not just that number, it would be the whole aortic complex as it was discussed. But what I suggest is like of course, the Indian population has a less life expectancy. But the patients who are coming for TAVR, we would have to assess them. And in that group, I don't feel that their life expectancy is any less than the European counterparts, because they are looking at a good life forward. So you should also have a clear, definitive lifetime management plan for the patient, that if you are doing a TAVR valve in a patient of 68 years old with a coronary height of 5, would you be able to hook the coronaries if the patient comes with you with the ACS at the age of 72? And second thing, how are you going to deal with TAVR valve and valve if the valve degenerates in next 8 years and the patient comes back to you? These things also pertain to surgery. This is just to outline these 2 points, and probably we also I can also see Rahul Gupta there. If you would like to add something to it.
No, Dr. Manik, I think all points are very well put and summarized. I would agree with your viewpoints, and I think we have to look at overall. I think you have very well summarized. So let's move ahead if there are no more.
Because I would just say one thing, because the lifetime management of TAVR was a different situation. So I just kept myself focused on this particular case scenario. And when we talk about 5 millimeter height, I just mentioned things. It's for a desperate situation, we go for this gymnast stenting and all. So indeed, my point is that, there are no data which is very randomized data of comparing minimal AVR versus TAVI. So we should not just think because the surgeons are doing from the small incision, that's going to translate into the clinical benefit, just matching with TAVR or approaching with TAVR. And the TAVR has proven is a test of time. As far as young patients and the redo TAVR in TAVR, we know very well that the low frame height valves can give enough access to coronaries presently. You don't need to be a special interventional cardiologist to cannulate those coronaries if your valve is intra-annular and low frame. And that also gives an opportunity to put a new TAVR valve down the line if such kind of patient develops a prosthetic valve degeneration of the given TAVR valve. So that happens to be, I kept it for the separate discussion altogether for that.
I said I'll just have a closing comments from all of you about the technique. That's a lot of cardiologists actually park the wire in the coronary and keep the stent ready when they think that it's probably end up going to be compromising the left main, and then go ahead and do the tower. Your comments on that, just to complete the discussion on that viewpoint.
I mean, I would. Oh, okay. Go ahead, Abhishek.
It is all anticipation how it goes, and we actually don't have much of data of how this chimney stenting is going to work. So if it is, as I mentioned during my discussion also, that if your patient is extreme risk, high risk, and surgeons are not ready to touch, you do it the chimney stenting. We don't know the long-term data of how the chimney stenting is going to work. So as I mentioned, for a desperate situation, such things exist. So any given case of aortic stenosis, it cannot be handled universally by a surgeon or universally by interventional cardiologist. It has to be, as it is mentioned in the guidelines as well, it's a heart team approach. And by CT analysis, if your CT analysis is thorough, your understanding of anatomy is thorough. As I mentioned that we are changing from expected distance from the ostium instead of just a coronary height. In tower, you can anticipate 99.9% of your complication way before you take a puncture.
I agree with Abhishek. The only thing I would say is that if you have a patient of low risk, which most of the patients are in today's scenario, are there in India, to be honest. And if you have low coronary heights, and if you anticipate to put a wire in a coronary, even with your gut feeling, then probably it's better to offer patient surgical aortic valve replacement, unless and until the patient is a complete no-no, or there are something which is not taken. As he already told, it is only for prohibitive and high risk that you would like to do such things, because you don't know the future of these the stents which are put as chimney. Because most of the times, if you are going to put a wire, it is very difficult at the end to judge how the leaflet is going to behave once you pull out the wire, because still the wire is in, the flow is good. The moment you pull out the wire, it behaves differently. There are chances of delayed coronary obstruction. So all these things considering, probably in the end, you would like to put a stent and come out for peace of mind. It is good at that moment, but we don't know how these stents are going to behave after 6 months. Of course, these stents are not there to solve the problem of coronary obstruction. They are there as door keepers or door openers. They are there to deflect the leaflet. So even if that gets stenosed, their cells are open and the blood is going to flow through. Most of the times they go well. We also have some 1 or 2 years data for planned chimney stenting patients, and so far it is good. But to hook such coronaries afterwards would be difficult. So again, elderly patients, high-risk patients, we are justified. Low-risk patients, difficult, intermediate risk, 5 millimeter. I would say if anatomy is very large, then it's fine. But if anatomy is borderline, then probably, but clearly it was written that the anatomy was suitable for TAVR valves. So I completely agree with whatever Abhishek said.
Vascular closure, I think when we are talking about high team approach with the cardiologist getting aggressive, and you end up with proglides, couple of them, and then you actually don't allow the surgeon to touch the patient at all these days. So quick comments on the proglide and the closure devices. How often you will actually require a surgeon to come in for that?
Less than 5% in Indian scenario, I guess. Because in India, we are not having a universal tower center. So most of the towers are happening, more than 50% of towers are happening in a centers where the volume is less than 2 or 3 towers in a year. So going with those things, and you are going as a proctor, so you just try to hand over most of the things to your colleague who is holding the case. So indeed, it's tiny bit higher on our side because in India, because of such things. Second thing I would like to say about elective femoral cut down. I think giving anesthesia itself is a bigger problem. Whether you are doing appendicectomy in an 85-year-old or 80 or 75-year-old patient, that carries a risk. So femoral cut down, that any anesthesia you are giving, that substantially nullifies the advantage of transcatheter procedure. I
would agree again. I don't consider local vascular puncture complications as complications. I consider them part of a TAVR procedure. At the same time, pacemakers also probably are part of procedure. I do not consider them as complications per se. I can see probably Dr. NC has some question or something to.
Sir, there is a question from the audience to the cardiac anesthetist. It's been written, then what's your opinion about the risk of surgery anesthesia, as the anesthetist observes all and can give a best judgment? Sir, I would like to say that age alone does not determine which procedure is best. Age along with a certain capacities matters, and a careful assessment with the clinical, anatomical, and the procedural factors, other than the rather than the surgical risk scores alone, govern the risk choice between the two procedures. That's the answer to the question.
Yeah, agreed. It was again discussed by Dr. Abhishek in his presentation that anatomical factors regarding the chest and probably the anesthesia risk was very well discussed. And yeah, I agree to it.
I think the MICS carries an advantage if for somewhat in a pulmonary disease where the chest dynamics are not changed substantially with the lateral incisions and the mixed sternotomy. But as far as the other risk of organ problems like having a bad kidneys or bad liver or very bad LV function, I don't think so that's going to make any difference whether you are doing a medial sternotomy or you're doing a lateral thoracotomy or right thoracotomy. So we are in so-called high-risk patient, everybody should extensively undergo the STS scoring system. We should realize why it is extensive. See, my surgeon can have an anatomical problem in assessing the valve, or the patient is a bad patient. So that's two difference. Why? Then now we go to the second stage. Why this patient is a high risk? It's an anatomical problem. It's a physiology. It's a problem, and that can give us rather a better idea in Indian scenario where cost is very important concern, that we can choose between minimal invasive versus the transcatheter procedure.
Okay.
I think we can end the session. We had a wonderful Dr. Manik closing comments, and we can end the session.
I think everything was very well discussed, and I think let's go to the next session. And many thanks to the speakers, the moderators, and chairpersons to join and host. Thank you.